I'd like to thank the organizer of the Oasis Con for giving me this opportunity to share my thoughts on management of spinal deformity secondary to osteoporosis. Spinal deformity in osteoporosis can be a focal kyphosis from isolated fracture, or a segmental deformity from multiple fractures, or proximal junctional kyphosis after previous spinal fusion secondary to osteoporosis. Focal kyphosis does not always happen with osteopenic vertebral fracture, which can be treated with vertebroplasty. But when there is a collapse and leading to a focal kyphosis, then it is appropriate to restore the lordosis of that segment by inflating with a balloon called balloon kyphoplasty that can restore some degree of lordosis with the procedure. Whether you do kyphoplasty or vertebroplasty, both have the risk of cement leakage, which is certainly more frequent with vertebroplasty. Cement can leak into vertebral vein and can lodge into pulmonary artery and can become an intractable problem of pulmonary vascular obstruction. It can also lead into spinal canal, causing paralysis, or can leak along the nerve roots, causing intractable radicular pain. It is important to focus into prevention of cement leakage as soon as it is recognized. It usually happens in the central vein of the vertebral body, and you can redirect the cannula as soon as you recognize some cement leakage. Go to the other pedicle and start cementing there. Alternately, after you have injected some cement, as soon as you notice some leakage, stop there, let that cement be set, and then inject further cement behind it. If you have a flexible cannula, then you can redirect the cannula so that you do not see cement leakage into vein or towards the spinal canal. Whatever you do, it is very important to prevent cement leakage and observe closely for cement leakage at every drop of cement being injected. It can be done using one C-arm, but we prefer to use two C-arm. The first one is kept for lateral radiograph, and we drape over this and then bring in the AP radiograph for further imaging so that we can see AP and lateral simultaneously during every drop of cement that is being injected. The take-home message is percutaneous vertebroplasty or kyphoplasty is potentially dangerous. Use two C-arms simultaneously if available. Watch for any cement leakage. And we prefer not to do more than 3 vertebrae at one session, because as tiny amount of cement may leak into the vein, can accumulate in pulmonary arteries in no time. Kyphosis secondary to multiple vertebral fracture is a different problem. Like in this unfortunate lady, 45-year-old, but had seizure disorder, was being treated with phenytoin, carbamazepine, etc., which are notorious to cause secondary osteoporosis. And despite initial treatment with vertebroplasty or kyphoplasty, she started developing unacceptable degree of kyphosis, and we had to do something. And do something means we did a long segment fixation, because strength in each fixation point is weak in an osteopenic bone. Whenever you correct a deformity, you have to do several segment fixation above and below. But despite that, the caudal fixation failed and we revised it, but still it was a disaster, a significant failure. Another mode of failure is when people do laminectomy. In this 79-year-old lady who presented initially with osteoporotic vertebral fracture in multiple segment treated with vertebroplasty, and later on developed kyphosis and spinal stenosis and was treated with laminectomy. And because the anterior column is already weak, with laminectomy the entire spine falls apart and patient developed progressively worsening paralysis and incontinence. And we had to do something, and once again, it is quite a long fixation. At the cranial end, we used caudally directed pedicle screws and a hook combination, and at the caudal end, we went to pelvic fixation, and we had a reasonably decent correction and recovery of the neurologic deficit. This is another lady initially treated with vertebroplasty for focal fracture, started developing progressively worsening kyphosis and paralysis in 76-year-old, and finally we had to do a long fixation, again with caudally directed screws above and cement augmented screws at the bottom end. In addition to that, we use these devices which indicate sublaminar tapes. As you can see here, these tapes are much more resistant to cutout of bone and is a good adjunct to the internal fixation in osteoporotic vertebra. With this combination of technique, we can still help these elderly population with osteoporosis reasonably effectively. This is another example where we used a combination of tapes, as you can see here, and cement augmented screws. Excellent outcome in this patient population is not infrequent, and in this lady, she survived 3 more years with an active, productive life, and then she died from a different medical cause, and her son wrote to us a nice email that thank you sincerely for giving us the years with her since surgery. Mom was only rarely using pain medicine. She had a much better lifestyle than she had in years prior. Our colleagues from Mumbai, Dr. Uday Pawar and Dr. Abhay Nene and his team, published their experience of vertebral compression fracture with osteoporosis and deformity and neurologic deficit, and they have classified different fracture pattern and recommended different kind of surgical treatment as may be appropriate. But the take-home message here is, never do laminectomy alone in presence of osteoporosis. And the last but not the least problem is proximal junctional kyphosis in osteoporotic bone. Like in this case, with flattening of lumbar lordosis and thoracic kyphosis, had a nice restoration with pedicle subtraction osteotomy. But as you notice, the cranial end fixation, the screws are parallel to the end plate, and in no time it fallen apart with the hardware pulling out and the bone coming out of the screws due to osteoporosis. It was corrected by caudal and cranial further extension, but still the screws were parallel to the end plate, and that fallen apart soon despite kyphoplasty of the adjacent segment, and she needed further extension of fixation. Once again, the screws are not caudally directed. This is parallel to superior end plate, and you can notice some degree of proximal junctional kyphosis even developing after 3 major surgeries. In this unfortunate lady, a 68-year-old lady with osteoporosis, developed back pain, was treated with cement augmented screws and posterior flexible stabilization and anterior disc replacement in 2 levels. In no time, she developed adjacent segment fracture, and this kyphosis was treated by corpectomy using a cage, a Coflex flexible device at the back end, and extension of fixation. Unfortunately, nothing survived. She collapsed at the level of the fracture where cages were used, and at the proximal junction, the screw cutting out of bone. We had to do some exploration, and you can notice the Coflex device and flexible device at the back, and we had to remove these devices and do an extensive fixation with a single or 1 pair of rod from proximal end to distal, and we used caudally directed screws and a cranial hook, and this combination survived even 5 years down the road with stable fixation. There are multiple examples like this. Like in this patient, we used caudally directed screws and hook combination. The fixation itself didn't fail, but her bone above the level of fixation failed with proximal junctional kyphosis treated with kyphoplasty, but she still had pain, and we had to extend the fixation further higher up with caudally directed screws, as I described earlier. Spine surgery in the presence of osteoporotic bone can be effectively done by augmenting the screw fixation at the anchor point with cement augmentation. You can use a simple solid screw by vertebroplasty through the screw entry point and then inserting the screw, or one can use fenestrated screw. It could be fenestrated by the side or side and end fenestration. But whatever you do, the idea is to safely inject cement before inserting screw so that the screw can get a better purchase. In this example, in a 78-year-old person, despite fixation with caudally directed screws and hooks, this did cut out with progression of multiple fractures, and we had to revise it with extension of fixation with not only caudally directed screws but also cement augmented screws here. There are several examples, like in this patient, we addressed with cement augmented screws with multiple segment fixation above and below. You have to have multiple fixation points both cranially and caudally when you are trying to do an internal fixation in presence of osteoporosis. And you can deliver an excellent outcome even in this elderly population with significant osteoporosis. But cement augmentation itself will not protect the fixation unless you treat osteoporosis promptly. This should be done both before and after surgery. We prefer to use teriparatide, which is first 34 amino acid at the amino end of 84 amino acid parathormone. This is the active segment of the hormone, and given in a low dose in frequent interval, like once every day, it stimulates the osteoblast to lay down new bone, which is a reasonably rapid process, as opposed to traditional treatment with bisphosphonate, which binds to bone and does not allow the osteoclast to resolve bone formation. In our experience, bone formation with teriparatide can take place even in a span of a month or 6 weeks' time prior to surgery and can effectively prevent hardware failure. Fortunately, Terifrac is much cheaper in our country, in India, than in the Western world. The other similar drug that can be used is denosumab, which is faster effective, shorter lifespan than bisphosphonates and is quite effective. So take-home message here is, in osteoporotic bone, fixation should be done by caudally directed screws, use of hook at the cranial end, use sublaminar tape, and cement augmented screws. It is important to remember that osteoporotic compression fracture, when you do kyphoplasty, it is dangerous, and watch for cement leakage. Kyphosis and stenosis in osteoporosis, when it is combined, do not do laminectomy alone, and surgery in osteoporotic bone needs to be associated with treatment of osteoporosis before and after surgery. Thank you very much for a patient hearing.